All right, so we're live. There are a few people that set up arrangements with me to pretty much just do the class from home. Those people that I made that arrangement with seem to be doing okay. I know that Monty came in the night, but I have another guy in Elk City that I made that agreement with. And but the thing about him is his wife or girlfriend or whatever is RN EMTI, so she agreed and she works for me. She agreed to help him, but outside of that, I kind of noticed that the people that did well or did what I thought was well on the test, which is passing. I think anybody that passed did well. They were the ones that attended. They are the ones that said, I come in here and you guys are studying before I come in. And Crystal, I know that you ask questions whenever you need to. So I think that showed in the grades, attendance and stuff like that. I'm not saying that it was me, because it's you guys put in the time listening to me yammer on. But I think it has helped. So I think it's important to at least watch the videos, Robert.
You better specify the right video.
So all right. No, I know that we kind of got off to a weird start on all kinds of different books late. You guys had a busy week here in Sayre. Some of the people over at Leedy, they didn't even get started, so they're going to take a little bit longer to do their first test. But hopefully they're caught up by test 2. So objectives of this chapter can be found on 304. Once again, I'm not going to read the objectives. Hopefully this chapter, because it's communications and documentation, hopefully I can give you guys some tips. We can get through it pretty quick, and hopefully it's just not me regurgitating things that are on the PowerPoint slide. One thing I would like to do tonight, after we do this, is pull up the National Registry check sheet for your patient assessment, because I think that if you guys study that or understand that, it will help you greatly on the test, on your patient assessment parts of the test, okay? And so we'll go over it tonight, and hopefully it'll make the whole primary survey and all that, hopefully it will make that all make more sense, how it flows. So, all right. So topics: communicating with your patient, communicating patient information to other providers, and then documentation. A lot of the stuff that you guys did in the earlier chapters with the medical terminology and the directional descriptors and things like that were to communicate information to other providers. So if you had to talk to a doctor, you could talk intelligently. Now, I'll just be honest with you guys. Out here in Western Oklahoma, the docs are typically pretty cool. Just tell them, hey, on the back, just below the shoulder blade, they had a laceration. They're cool with that. They're not like, there's a laceration to the dorsal side that is, just inferior to the left scapula. You don't have to go into all that detail. So they're pretty cool. So I will tell you this, even at the EMR level, documentation is what will save your butt. Okay. Luckily, we work in rural areas where we're not called into court a lot. We're not sued very often, but don't ever think that you can't be where you won't be, because then it'll happen. I know that my service, since I've been there, we've had several times where we've gotten called at least for a subpoena to do a deposition, and it's been over things like shootings and things like that. That stuff does happen out here. So your documentation, make sure that you do your best to do good documentation. A lot of services these days are going to what's called an EPCR, or an electronic patient care report. And so it kind of guides you through your documentation. But I encourage you, and I encourage my people whenever I read their charts, if I can't read that chart and have a really good idea what happened, then you need to change or add or whatever to that chart, so that whenever I read that chart, I get kind of a picture of what happened on that scene. I could tell why that patient was transported, what they complained of, what got them into that situation, what the medics did. I should have a pretty good picture of what happened because, as Matt could attest, if you don't document it, it didn't happen, right? So whenever you're doing your guys' reports, you guys are pretty thorough on your reports on what the subjects say to you and things like that. Same thing here. Sometimes you get called 2-3 years after the fact, and like when I worked in Wichita, it was really hard for me to recall some of the calls I got called up on. Recall the calls that I got called up on. Huh. So anyway, documentation is important. Communication, and then well, I don't know why they did that. Oh. Yes, Crystal, if you could hear me, yes, I think you do have yourself muted. I want to read the rest of your text there. No, I cannot hear you banging dishes around. So, all right. So, yeah, you have it muted. So, anyway.
I mean, I'll unmute it and you can listen to me, but I think that it'd be.
No, I'm good. You go ahead.
Okay.
So, you were dispatched to a holiday party for a patient who has passed out. You arrived to find the patient sitting on the carpet, leaning against the couch. She appears to be one of the youngest family members at the party, about 20 years old. There are 12 nervous family members standing over the patient as you're trying to decide what to do. How should you approach a scene from a communication standpoint?
Who the hell gave her alcohol?
Exactly. All right, fess up. She is 19 or 20. Who gave her the alcohol?
Now, actually, when you walk in, you want to introduce yourself real quick.
Oh, you read the chapter.
It's called therapy communication.
Man.
You want to introduce yourself real quick to me? We're at high speed. What?
All right, hey, bravo, okay?
So basically, you want to
Screw these guys.
introduce yourself to your family.
Awesome. So, yes, you want to do therapeutic communication. You want to go in, you want to introduce yourself, and obviously you want to start by questioning, hey, what happened? You don't want to jump to the conclusion like, who gave her alcohol?
That'll be my next
Well,
one.
that's the police side.
So communicating with your patient. So accurate and efficient communication requires a minimum of noise, adequate lighting, privacy, at the patient's level, no intrusion into personal space, and minimum of interruptions. I'm going to give you a few things here. So minimum of noise. Why do you think that is? No, you already read the chapter, but hey, go ahead.
Less distractions.
Yeah, less distractions, right? So do you have anything to add to that since you read? Less distractions? Yeah, okay. Adequate lighting.
Adequate lighting means that you want to have adequate light where you can see the patient, to know what's going on with the patient, see
Yeah.
the patient's breathing,
And they can
and all
see
that
you.
stuff.
Yeah, so you guys want to be able to see each other. Matt, is that always a reality in our world? Adequate lighting? No, it's not. Go to a lot of houses and you're like, seriously? People live like this? They do have electricity, right? That's cool. To each their own. I'm not judging. But yeah, definitely want adequate lighting. Privacy. I'll tell you what, sometimes you could get a better story if you separate the patient, especially like a 20-year-old female, from her parents. It's even more so with a 13 to 17-year-old female. Separate her from her parents. All of a sudden, you get a whole nother side of the story that the mom said is impossible. She's possibly pregnant. Oh, no way. And get her in the ambulance. Well, yeah, there is. And so you want to get at the patient's level. Nobody likes anybody to tower over them. Freaking cops do that to you all the time. So don't be like the cops. He's going to arrest me here in a minute. So anyway, it's intimidating to have somebody stand over you, and it makes you close down and be less willing to communicate. No intrusion into personal space. Anybody have that uncle that, man, he just talks right there in your face all the time? And you're like, dude, you got to back up a little bit to talk to me. Some people and some cultures understand that, some cultures, personal space isn't as big of a deal, but a lot of Americans, and there are some people out there that don't care, but most Americans want you to stay at least 3 feet away from when you're talking to them. Now, obviously, as you become more intimate with each other, not in that kind of way, but once you guys know each other more, you might let them get a foot and a half or punch you in the shoulder or something. That's no big deal. But don't intrude into their personal space unless you have to. If we're doing interventions and we're treating this patient, sometimes you have to be within that personal space. In the back of the ambulance, it's dang near impossible not to be in their personal space. Whenever I was flying with Eagle Med, we flew in a A-Star 350, and the patient was all up in my personal space. Their head was in between my legs, right at my crotch. And so, it's just something you got used to because the helicopter is so small. So I could just look right down at the patient. They're right there.
Got something in your hand for set down on their face.
You want to make sure you shower before you go to work. So, no intrusion, and then minimum of interruptions. Guys, this goes from not only from you, but the person you're working with. It drives me friggin' insane whenever I'm trying to interview my patient or talk to my patient, and I have a little parakeet on my shoulder, which is my partner, firing questions at the patient too. Well, if I wanted to know that right this second, I would have asked that right this second. And if you want to take this patient, you could have this patient. Let me give you a tip. Whenever you are interviewing a patient, please, you interview the patient, not your partner, okay? And as a partner, give that medic their space to interview the patient. One, the patient really starts to kind of get confused on who they're talking to. And the other thing is we just get off our line of questioning, get distracted, and then a lot of times I have to go back and ask some questions, and that really, you start to lose your patient's trust when you have to repeat questions over and over again. Now, if that being said, if they think something's not that big of a deal, once you kind of, wrap up or say to your partner, hey, have you thought about this? Did you ask them if what was their last oral intake? That's not that big of a deal. It's just whenever one medic's firing questions and the other one's firing questions, and you both are firing questions at the patient. Patient doesn't know who to talk to. It really creates kind of a weird situation. Not really agitated, but more confused. They don't know who they should be talking to, and it's overload. So all right. So accurate and efficient communication, active listening, guys. I see this over and over again, and I'm guilty of this. If you're going to ask a question, be ready to listen to the answer. Okay. Don't ask them for their date of birth while you're doing something like getting your nasal cannula out when you're not even listening to them, and then you have to turn around and ask them again. Once again, I got to plug my computer in. Once again, they're going to, no, 7%. Oh, hurry. There we go. Whew. All right. So make sure that you're ready to listen whenever you ask a question. I highly recommend that you use a small notepad to write down the answers to the questions that you ask. I promise you'll have a lot of stuff going on, and you're going to forget some of the answers, okay, especially the date of birth. Unless you're that person that is really good at just remembering stuff like that. And there's people out there. And if you are, you are, and you know how to handle it. So barriers to communication. What do you think some barriers to communication are?
That would be music, loud music, people talking to you, people talking to you, stuff like that. Yeah, you can look at
distraction from noise, right? Other barriers to communication, maybe they can't hear, would be another one. If you look at this guy, he's getting ready to put this non-rebreather mask on her. Do you think that will maybe make it hard to understand what she's saying? A lot of your elderly patients are soft-spoken anyway. There's some out there that will let you know what for, but a lot of them are pretty soft-spoken. procedures, and then body language. Guys, obviously, you want to communicate any procedure that you're getting ready to do on this patient, right? So you want to, if you're going to take their blood pressure, feel for a pulse. Hey, I'm gonna check your pulse real quick. Okay. Hey, we're gonna put this blood pressure cuff on. We're gonna take the blood pressure and see what your blood pressure is. Now, obviously, if they're in cardiac arrest, you don't have to say, hey, I'm gonna do these compressions on you. Obviously, that's you don't need to go there. But, body language is another thing, and I'm really bad about wearing my mood and through my body language. But sometimes I'm not really in a bad mood, but I'll stand there with my arms crossed. Maybe I'm cold or something like that. But what does that tell your patients whenever you cross your arms? What's that?
It's a defensive posture.
Yeah, it's a defensive posture. It's a closed posture, and so they might not know really how to take me. So be cognizant or aware of your body language. Okay. Patient interview techniques, open-ended questions. What made you call for an ambulance tonight? Open-ended questions will get you a lot of information, but be careful with it, okay? Sometimes, like we were talking about your past medical history, you might get a huge list starting with their appendix removal in 1918, and they'll go from there. So be careful with your open-ended questions, okay? The closed-ended questions, okay, you told me about your chest pain. Do you feel pain anywhere else? A closed-ended question basically has a real short answer to it. No, I don't feel pain somewhere else, or yes, I do. Your open-ended questions allow them to tell the story or talk more. Closed-ended, obviously, they're just a simple answer. Let's see what they say about pitfalls in here. I want to see what's pitfall, since you read the chapter. Does it say anything about pitfalls? What's significant about that?
I didn't see about pitfalls in here,
Yeah, I'm wondering what that's all about.
not when I read it.
Communicating patient information to other providers.
Pitfalls that can interfere with the special patient review.
Okay.
That's all basically all it says.
Okay.
Pitfalls.
So it's pretty
It's on 309 in writing form.
pretty basic explanation. All right. So, guys, as an EMR, most likely you guys are going to be giving reports quite a bit to incoming crews, right? So you're going to want to develop your way, and I might be able to find you guys something, or there might be something in the book. Have you guys ever heard fake it till you make it? So if you have to get one of these sheets and basically fill the sheet, fill in the blanks in the sheet to give a report until you remember that format, then do it. But you want to be consistent in your reports and kind of give them the same each time. Why? Well, so you don't forget to tell something. And so if you're always doing it in that same order, you won't forget to tell important details. Let's see what else. Let's see what else they say in here about communicating with other providers. So you want to make sure that you communicate the patient condition initially and current. Patients. So if you got there and they're unresponsive, upon our arrival, they were in a car wreck, maybe hit their head or maybe a football game. Upon arrival, patient was unconscious. About 5 minutes ago, they came to and they're a little groggy, but they're starting to come around a little better. Patient's age and sex, chief complaint, brief pertinent history of what happened, how you found the patient, relevant past medical history, or relevant past medical and traumatic conditions, vital signs, and then pertinent physical exam findings, care given, and the patient's response to that care. So it's not necessarily in that order, and whenever we get done here, I'll try to pull up what I have for my crews, and basically it's a fill in the blank thing. We don't run enough calls in Roger Mills for that I feel like my crews can become proficient at giving a radio report. So I have a little blank thing for me to fill out. Basically, it has all this same information in it. If not, Robert, for your guys, they make some really nice, or you can find really nice ones like an EMR report template or something like that online. And you could kind of incorporate it into maybe some kind of sheet for whenever you want to write stuff down for the incoming crew, and it'll help you guys give reports to them. They're easy to find.
Signers already got this place.
Okay.
So since we're following their policies and procedures.
Well, they have a report, do they? But do they have a thing they want? Do they have something that helps you give a report to them?
They're gonna do a simplified
Okay.
report, basically laminated.
Okay.
That way, I don't have to place it.
Yeah, cool. So radio communication, Robert probably should actually teach this little section because I believe that he does a lot with radios. But you have portable radios, which are the ones that people carry around on their hips. You have the mobile radios, which are the ones that you see in the cars. And then you have the base stations, which are typically found in like your dispatch centers or your, what is that? What is a dispatch center actually called? Public answering safety point. So remember that, guys, because I noticed that some people miss that. We could go over the test tonight if you guys want to. Leedy, do you guys have anybody there that hasn't taken the test? The only one that I know of is Darren, I think. Okay. Oh, we'll go to the test anyway. So general radio communication, general rules, speak slowly and clearly. I wouldn't speak Forrest Gump slow, but definitely speak slowly and clearly. Hold the microphone 4 inches from your mouth. Only speak when necessary. Listen before transmitting. It drives me insane whenever people start getting excited and they walk all over each other. Yeah, because now nobody's communicating, right? Do not transmit names or confidential information. Drives me insane whenever they say, go to the so-and-so residence, and then they refuse to give me nature call because they just called me. That's a HIPAA violation. You just called me to their freaking house. I, for my safety, need no nature call. Speak professionally. I'm the worst at whenever I get a little bit irritated of not speaking professionally. And ensure your batteries are charged and follow local procedure and protocol. Another thing is whenever you key up, don't start talking right away. It takes a second for that to open, that line to open, whatever you call it, for it to key up. And so you might give it a one count or 2 count before you start speaking. A lot of services will say like we're Roger Mills Ambulance to Cheyenne. Okay, so we say all that, or Roger Mills Unit 24. As long as they get that end part, they know who we are, right? And so you say that kind of whole beginning part of it. Okay, sounds good. So anyway, make sure you give it time to key it. Don't just key up and just immediately give important information. So, special communication situations, the challenge patients, take your time, ask the family how to communicate with the patient. Do not assume reduced intelligence and do not shout. So we could use a couple different situations here. And it looks like we're kind of talking about the cognitive challenge patients here because of what they're saying. And so I told you guys kind of at the beginning of one of the first classes, just because they're blind doesn't mean they're deaf, so you don't have to yell at them. Guilty, okay? And same thing with old people. Now, sometimes the family will tell you she can only hear in her right ear, and you have to go over to her right side and speak directly into her right ear. Well, that's how you have to talk to him, then that's how you have to talk to him. So, but I like that. Do not assume reduced intelligence. Sometimes they're very sharp. It's just like maybe they can't hear. So anyway, and do not shout unless you're instructed to. Deafness. Obviously, if you have a deaf patient, kind of give away a test question here, but you're not going to do pantomime, all right? You're not going to act out the situation for the patient, all right? A lot of deaf people can read lips, so make sure that you have a well-lit area and where you can talk to that patient, and then.
One right
Are you back?
Lord, I'm so sorry. My daughter.
So, no worries. Geez, troublesome trucks. So,
Say hi.
bye.
You
All
put
right.
that.
Is she doing class 2? Oh, they muted us. They don't want to talk to us anymore. So,
No. Okay, so okay. Well, she's attending this class, I guess.
oh, yay.
See it. You
So-
can't see my lovely pumpkins and my lovely daughter anymore, right?
No, I can't. Nope.
Okay, good. I'm so sorry.
Pumpkins are awesome. All right. So deafness and blindness. Obviously, like I said, if they're blind doesn't mean they're deaf. They can hear just fine. Actually, probably a little better than you can. They get that fine tune. Mental impairment. Once again, you might have to find out how to talk with them. Differentiate AMS or altered mental status from normal status. A lot of times whenever I go in and I have a patient that I'm like, whoa, I just look, and I don't do that. I'm not like, whoa. But I do turn to the family and I ask them, is this their norm? Is this how they act normally? Or do you guys think that there's something going on? Oh no, this is how they are normally. Oh, okay. I'm gonna throw this out there for you though. If you feel like, and sometimes what I kind of read like the patient's family too. I've had patient's family tell me, yeah, that's normal. Well, I didn't feel right with it because number one, he wasn't acting right, okay? But their answer wasn't a clear, crisp, yes, this is his normal mentation, or yes, this is how he acts normally. They're like, they're a little leery of it. Yeah, this is how. So I just looked at him. I said, I feel more comfortable if we just go ahead and take him in because they're going to refuse. And they said, okay. Well, he ended up having a bleed. So kind of watch that. Don't just take their answer. Listen and watch their reaction. If they're hesitant on something, there's something there. Even though that maybe they don't want to admit it right there at that point in time, there is something there, or they would have just answered you flat out. So the other one, and I don't know if we'll get into it on here, but is Spanish. We've talked about different ways of dealing with Spanish from apps. And sometimes, you know what? You just have to tell them to get in and let's go. I would say a lot more foreign people understand us a lot better than we understand them because English is taught everywhere. But don't assume that everybody understands English. You got to try your best. We're not, like Texas where we have a large Hispanic population, but it would be nice if you could learn or basic medical Spanish.
Yeah, look. It's not on you.
So anyway. All right, so the patient seems alert and oriented. You introduce yourself, perform a primary assessment, and begin to ask the patient some history questions. 3 or 4 family members are still lingering around trying to help the patient answer questions. If the patient doesn't seem to want to answer any questions, why might the patient not want to answer? Why might not want to answer questions?
Because the family members are there.
Yeah, because the family members are there, guys, and even sometimes when there's a good relationship with family members or there's nothing wrong, they just don't want to answer some of the questions because family is there. If you get a hint of that, separate them out. Or have a family go do something. Hey, can you go write down on a piece of paper her name, date of birth, her allergies, and all that, and send them away. Get them out of there. So.
And a lot of times, older people, they like to do it themselves. They don't like others to do it for them.
Yeah. So this is a pretty common computer that she has right there. It's a Panasonic Toughbook. I would say the majority of services, this is what they use. They spend a tremendous amount of money on them. They're very nice equipment, kind of water resistant or waterproof-ish. The patient can actually sign on the screen. So if you come across one of these, and the staff, please take care of their equipment, because I know that those things, I think that the Toughbooks, buying a used one's over $2,000. So you start buying the new ones, you're a lot more than that. So they're pretty pricey. And I actually chose to go with Microsoft Surface tablets because I spent $800 on them. And they're actually really strong, and they're a lot faster than the Toughbooks. But I do run the risk of a shattered screen, which has happened to me before. So here's your documentation, your pre-hospital care report, PCR. It's required for continuity of care. So you guys need to come up with your system where you're going to help Signer get the information. Signer has to then, whenever they drop a patient off at the hospital, they have to have that chart turned into the hospital with, I don't remember if it's 24 or 72 hours. It's either 24 or 72. But they have to have that chart to the hospital. I'm going to tell you that we're really bad about doing that. A lot of times we'll have hospitals call us up, but the hospitals are actually doing what they're supposed to do. They'll call us up and we'll just fax them a chart because we forget to send it. So components of the pre-hospital care report: run data, patient data, and narrative. So you're pretty self-explanatory, I guess. So your run data is going to be the things such as the address you ran at nature call, your mileage, your times, all that fun stuff. Patient data is anything that has to do with the patient, their chief complaint, their signs, their symptoms, their medical history, their allergies, medications, anything about them. Then the narrative is where you get to tell your story. Okay, responded to a 61-year-old male having chest palpitations and shortness of breath. Upon arrival, found him sitting in his truck. Patient denied any other pain or discomforts. Blah blah blah. So components of a pre-hospital care report: the patient refusal. Guys, I'm going to tell you, be very, very, very. And actually, I know that talking to Robert, you guys aren't going to do refusals. But if you ever get into a situation where you are doing refusals, you work as a driver for an ambulance. You guys run an MCI, and you guys have the medic on there wants you to go get these 3 people's refusal. You want to make sure that you inform them of their rights. So you do realize that your injuries that may be masked. They could worsen to include death. You do understand that you can recontact EMS if needed. Okay, great. You need to get the information, their demographics. You're still going to write you should write a more detailed report on your refusal than you would on a transport. A refusal is your biggest opportunity to be sued. Okay. My dad, you guys didn't treat my dad and he died. Well, your dad wouldn't let us treat him. And here's the report. We informed him. Your dad was ordinance times 4. We kind of went over some of that in one of the earlier chapters, that you can't let somebody that's cognitively impaired refuse, right? So they can't be on drugs and alcohol. They have to be a sound mind. They can't be confused because of hypoxia or something like that, right? So fax a document, advise the patient that further care and transport is warranted, advise the risks of refusing and steps you took to convince the patient to accept care. If you try to, after informing them, you try to explain to them 3 times that they have a chance of dying, I'd put that in there, okay? So, fax, advise patient and or family to call back if needed, and never leave there without telling them they can call back. Encourage patient to seek care elsewhere. hey, if you guys don't go with us, at least go in and get checked out with your provider, okay? And then took steps to ensure that someone remained with the patient. This isn't always something that you could do, but if you do it, let's say that you're at a car wreck. My dirty little trick is I left a patient in care of Roger Mills County Sheriff Office. Even though that they don't have direct custody of the patient, that patient's sitting there talking to them about the wreck and stuff like that. I just turned it over to them. So, and then sneak a signature from them sheriff officer, the police officer. Matt's ignoring me today. So, anyway. So you're ignoring me today. So PCR is a legal document, objective documentation. What is objective?
It's the factual, whatever you.
Factual. What's the subjective documentation?
What her is,
Yeah, what they're saying, what they complain of, things that you can't prove. So let's say like I have pain too. Well, I can't prove they have pain to their leg, so it's subjective. Now, objective would be notice angulation to the leg, right? That's very objective. So, and then controversial statements. I'm not exactly sure where they're going there, but guys, leave your opinions out of the chart. Don't say the patient was drunk as a skunk. Say patient smelled of ETOH or patient smelled of alcohol. All right. So anyway, don't put controversial statements in your report. Now, with that being said, if they say something and you're going to quote it because you feel it's important to the call, put it in quotations, okay? But be very careful when you do that. What the? Special reporting situations, we talked about this already a little bit. Abuse, assault, gunshot wound, sexual assault, and infectious disease. Remember that for this thing, but understand that. Dang, he stuck his hand on the barrel there, didn't he? What? That wasn't.
self-defense.
Yeah. That wasn't a long shot. That was a don't shoot me, and they shot him in the hand. But anyway, understand in Oklahoma, and I did get confirmation from Robert, EMS is only required to report child and elderly abuse, and that includes incest and rape. Okay, so now where we get around that is one: am I going to go on a gunshot wound without the police officer there? No, I really shouldn't. And two, whenever we do transport these patients, we're transporting them to a hospital. They are required to report them. So, but anyway.
Out here for the gunshot when the cops are in here.
Oh yeah, they're probably the ones that shot him, right? The cops shoot everybody. Hands up, don't shoot. Still ignoring me. Come on, I'm just joking with you.
In fact, I got it from my dude. Sorry, asking police.
Oh, really? They really say that?
I walked in there and the word or something, they're like, hands up, don't shoot. I said, you just lost my business. And I walked over to Subway. It's been a while. Probably not very much. You weren't there that day.
What shift was it on?
What shift do I learn?
Night shift? Day shift.
That was a day shift.
And employees get in trouble, so anyway. Transition, patient remains stable, you complete vital signs, a history of physical examination. EMS arrives and you prepare the transfer of care. I didn't see if.
Now, if it's something traumatic, you're gonna tell them everything that you've done, and then they're going to get the patient in the ambulance, they're gonna go ahead and start their care. If you give them the report afterwards.
No, you want to go ahead. I mean, okay, so I'm going to tell you that you should go ahead and give them report as you're walking up.
Okay.
But I will also tell you this: there's going to be some a-hole medics out there that you're going to try to give them a report and they're not going to listen to you. You know what? As EMS, there's a lot of nurses out there that I'm going to try to give a report to and they're not listening to me. But I have a better chance of you listening to me is if I'm walking up, I start talking to you as I'm wheeling the patient up. They don't have my patient yet, right? So as the medic come up, hey, we have this case, a 20-year-old female patient. Family stated that she went unresponsive. Blah blah blah. This is her blood pressure. This is her vital signs. This is her history. This is what we've done, and so forth. They're going to be more likely to listen to if you don't wait till they're with the patient.
Right.
If you wait till they're with the patient, then they are going to just ignore you.
And then once the patient's transferred, that's when you give your report, your written report to them at the hospital or at the ambulance barn.
That's something you guys will have to work out. Typically, with me and EMRs, if you just have a little piece of paper
Right.
that you could give me the stuff like the name, date of birth, the stuff you have found out, man, that's awesome. Tear that off. If you can make do two of them, one for you, one for me, tear it off and give it to me. That's awesome. I don't have to have your report.
Right.
But I don't know what signer's policy is going to be. I don't know what your guys' policy is going to be. They may want you to go back, finish your report, make a copy, and send it to the signer. That's just going to be between you.
That's just a follow-up.
Yeah. Yeah. So that's something that you'll have to kind of get established. All right. Oops, back. Define the following terms. Therapeutic communication.
Common voice.
There should be a
Common voice, introduction, subjugation, examining members.
conversing with the patient in a comforting and empathetic nature. So, personal space. Yeah, I like that, your bubble. Barriers to communication.
Deaf, blind, mentally.
But where it says in the book, you're supposed to also be if you're holding it up, writing questions on it, right?
Oh, yeah. Open-ended questions. Okay. Closed-ended questions? Portable radio. Mobile radio. And then base station. What's a PCR? Care report.
Care report.
Yep. What is continuity of care?
The care that I provide, and then when you get there, the care that you get.
Yeah, the continuation of care, right? Run data.
Where, time.
There should be a little
time.
list of basically anything that has to do with the run, address, mileage, times, all that fun stuff. Patient data.
Vital signs, the reason why you're there.
Yeah, basically anything with your patient. So their medications, their allergies, their history, their chief complaint. So what's the narrative?
Everything that you've done, straight to the point.
Yeah, basically it's where you kind of
This is
tell
what
the
we
story,
found,
right?
This is what we've done.
Disposition.
That's where the patient's still only after years there.
Destination of patient following your care. I think somebody just said that, didn't they? So, objective,
What happened that you see,
okay, and subjective,
what they say happened?
so the type of communication used to help a patient and calmly reassure him is referred to as blank communication. When starting a patient interview, what type of question is best to ask? Open-ended, yeah. So, hey, what's going on today? So patients with hearing difficulties will often be able to communicate by seeing your blank. Okay. And I think we pretty much, besides, I would know the general rules for radio use for the test. I probably have an idea of the reporting situations. And I would probably go ahead, I mean, all those, I would go ahead and all right. So that's it. What is the date? Tuesday? Let's take a little break. I'm going to pull up what I was telling you guys, the check sheets. While you guys take, let's come back at 7:15.
7:15. Remember what day that was? Okay with that. Oh, let's do it. Wow, we got nothing else. Still not fired. Okay. It's been a while, but. Should've told me that before, shouldn't I? So, I'm not gonna do that. You're gonna do it.
You worried out of it. One ones I don't care too much for.
Well, there's nothing disrespect from me. I don't know.
I noticed that when the door, no, it was on the wrong side of the door. Trying to go in that one over there, office. Whose office? Remember. Oh. All right, so we're gonna do the question, chapter review.
Yeah,
Oh, you got the answers?
that's what I'm talking about.
the answers.
No, I didn't. I answered and then I checked, make sure that I want.
All right. Therapeutic communication is best to be described as,
Where you at, dude?
every,
I'm on the
oh, you're going all the way back.
practice examination.
No, okay.
I'm on page number 323.
323.
Yeah, it's fine.
Well, we still got after you.
I did that already.
I'm sorry. I'm doing the section.
Yeah,
Section 3, so we're just going to quickly go over chapter G. Okay. Go ahead, there's function one. Nothing behind the shrub to protect yourself. You fucker.
They're not today again. You feel me?
Now, cover.
Other concealing it behind something that's gonna block bullets, remember that?
Mm-hmm. Like not attraction.
Yeah.
As you approach the scene of a reported motor vehicle collision, you can see that one of the vehicles involved is tangled.
Stop the music and operate, and then try to take stuff on the phone and then talk and shit, supposed to be. Yep.
That source of information will determine the safe distance from a particular type of material. That's your thumb, what that is.
Yeah.
You have responded to a call for a building that collapsed on the foundation. You can hear that there's two people yelling for help from within the road. You should.
I put it on that.
Yep. You don't have specialized areas. EMR assessment mechanism injury determined.
They've already started the section review of that.
Yeah, I think it's very angry.
Oh, it's just now for the 15.
They were, I was like, y'all should wait for the rest of the.
You ain't saying anything. You've been doing your job.
They should already be in here.
What?
I tried.
I went that way. No, I didn't see anybody, so I went up that way. How'd you guys get back in here?
I was out there.
Hey, what's on your windshield? That symbol?
It is a Visser. It is basically the Vikings. It's their compass.
Oh.
It's used as a protection symbol that you won't get lost.
That's a nice thing to have on motorcycle. Because our little group, whoever was the lead, has, got lost a couple of times.
Well, and it also has to do with whenever they're in the boats going through the storms. Going through the rainstorms. Like, I don't know. I just thought it was cool. I actually, my grandma is German, and so I was actually looking for Norse stuff, and on the motorcycle one, there's the alphabet around it. That's the Norse alphabet around it.
That's pretty cool. See you on. All right, where you going?
So, let's see if we can make this where we can see it a little bit better. I can zoom
There's
in.
Bob right there.
All right. So whenever you guys do your stations and even take your test, this would be a good thing to study. And you guys have access to this, right? I know you guys do, because I shared it. Just do you know how to get to it?
Yeah.
Okay. It's in your email, or if you know, or
I'm gonna put my email outside. Just click on it. It'll open.
or also you could just log into your Google account, and it's in your Google Drive. Now, if you don't have a Google account, you can sign up for a Google account with your current email address. You don't have to take a Google email address, all right? So this is kind of how it flows. If you notice the very top thing, takes or verbalizes appropriate body substance isolation precautions, then scene size that determines the scene is safe or the situation is safe, determines the mechanism of injury or nature of illness, requests additional EMS assistance if necessary, and then consider stabilization of the spine. So that's our scene size up. Remember, we had a whole chapter of it, right? And there it is right there. That's all it is, okay? And then you go down as you continue on, so as you're rolling in, and this is all done as you're coming in. So as you're walking up, consider stabilization of the spine. If they've been in a rollover accident, obviously you're going to stabilize the spine. So primary survey determines responsiveness and level of consciousness. So you're going to use that AVPU. What is AVPU? No,
Oh,
not awareness,
Painful
not awareness.
and unresponsive.
It's an A, but it's not awareness. Alert.
alert.
Okay. So then determines chief complaint were apparent life threats. So if you don't see any obvious blood spurting, where are you hurting? My leg. Okay. But if there's blood spurting, what are we going to do? We're going to go ahead and take care of that right now, right? Let's say that they're unconscious. So you can't really determine the chief complaint because they're unresponsive, right? So you're going to assess the airway and breathing. If they're not intact, what are we going to do for them? If they're not breathing, we're going to bag them, right? So determines, and each one of these has, or not each one, airway and breathing has 3 points. Assessment of it, assures adequate ventilation, and initiates appropriate oxygen therapy. Okay? So assess circulation. And you have, it looks like 3 points here too. So assesses or controls any major bleeding, checks for a pulse, and assesses skin, either skin color, temperature, and condition. Okay, and remember that you could do these in any order. Remember where it said that in the book? This section, you have to do your scene size up first, then you have to go on to your primary survey. For this test, I would know what is in each section. I would know what is under scene size up. I would know what's under primary survey, and then I would know. And then you get through your history taking. That's pretty obvious. It's your OPQRST and sample history, right? And then your secondary assessment, which also consists of your vital signs. So your secondary assessment assesses affected body part or system. And is this the trauma one? Or yeah, medical. And when we get to medical, you'll see that the trauma will have the head to toe at your secondary assessment. So let's say that you're controlling the airway. Are you able to do that secondary assessment?
Not if you're by yourself.
Not if you're by yourself, yeah. Then your vital signs, and I know what vital signs they want on here, and then reassessment. Guys, this is something that you probably should start studying now. These sheets that I sent to you, once we start doing these labs, we'll go over these. I think there's 4 or 5 scenarios, over them again and again and again, until you guys basically are able. You should have these sheets to where you know each and every step. You have it memorized, and then here's an important thing: know your critical fail criteria. Okay.
I got a question for you about what you said.
Okay.
Is it gonna be like the firefighter wants us, we gotta verbalize, have the things to skill and verbalize like the Donnie gloves? Or do you actually put the gloves on?
You're going to verbalize a lot of it. So, yes. And then you're going to end up with reassessment. But studying this sheet for the test will help you out. And there's also I'll open up the trauma one too.
Yeah. I've seen it, I just can't remember which one it is.
I'm gonna send it to my emails at work and send it on.
Yeah, I definitely print this off. So here's your secondary assessment on trauma. Notice the only real difference is you're doing your head to toe assessment here. Okay? Your scene size up is still the same. Your primary survey is still the same. Okay?
Out from medical or trauma?
Yes.
Okay.
History taking, you're going to try to obtain a sample history if you can. But then your secondary assessment is where you change your vital signs. It looks like they're a little bit different, and then you're still going to reassess, okay? You will do these stations.
But you'll be teaching it though, right?
Yes, yeah, we'll be going over them.
You're gonna talk to that checking us out, though, is what I'm saying.
Possible. What I'll probably have to do, because there's how many stations? There's cardiac management, trauma assessment, medical assessment, ventilation, and oxygen administration. I'll have to see if I can get anybody that'll volunteer to help me out with these stations. I know Leedy, I'll have people that'll volunteer. If not, it'll make it a long night for us. All right, I was wanting to show you guys. So here's I just did this for my people. Let me zoom in on it here. Okay, so basically this is what I was kind of talking about. If you have something like this where that gray, and how it is on our sheet, if you just write there, you're going to write right over. But anyways, it's so you'll say this is Roger Mills County Unit 24 to Great Plains Regional Medical Center. This is Rob Stevens, paramedic. We are currently en route to your facility with a 5-minute ETA. En route with a 5-minute ETA to your facility with a 61-year-old male patient with a chief complaint of palpitations. The patient stated that he was sitting in his recliner and started having palpitations. The patient has a history. If it's whenever you're doing this, notice it says pertinent history to this call. All right. If none, leave this off. And then the patient currently has the patient, and this right here on a medical you don't have to do because it's findings of physical exam. The patient is alert and oriented with a blood pressure of 160/80. Heart rate is 140. Pulse ox is 99% room air. We have administered, started an IV, administered Cardizem, did a 12 lead. Do you have any further questions or orders? So, basically, you could use something like this. I'm not saying this one because this one's different than what you guys are doing. This is a transporting to a receiving. But you guys could build something like this that flows. And I would use this until you got to where you memorize it. It's harder for me to read it than just to rattle off the radio report. And I'll be honest with you, it probably took me a good 6 months in a busy service to get comfortable giving radio reports. Okay? So it's not something that it's easy. You will stumble and bumble if you don't have something to write it down. So anyway, we could go ahead and we can go over some end of unit questions if you guys want to, or it is right now it's 7:25. It's whatever you guys want to do at this point. Reedy, what are you guys going to do? They may not be there right now. Well, they texted me she went to a parent-teacher conference.
Yeah, let's do the review questions.
I'm just going to tell them that you guys are going to do it here. We'll just send the broadcast. Okay. So, and then I'll hang out with you guys. So, do we need, just send this call. Hello. No, you got your microphone muted. That's weird. Let me see something here. So it's still on our screen. It still shows that your mic's muted. Let me see if I could unmute you. No. Let me see here. Yeah, definitely. Yeah, you're. I don't know what's going on. Okay. Try talking. No, it went red again. No, I can't. I don't know what's going on with it. Your microphone was red, which tells me that maybe it's not. Maybe it just needs to be restarted or something. No big deal. So, but we're just going to end the broadcast anyway, and these guys are going to study here, and I'm just going to hang out with them while they're studying. So, Oh, all right. Talk to you later. Do we even need to have class tomorrow is a question. Or do you guys, I mean, you guys could meet together. I could come up here and hang out with you. You want listen, I'm okay with it. I think you guys need to use the time to study. Whether you need me here or not, that's kind of up to you guys.
We'll give you that off too.
So, but yeah, I mean, it's up to you guys. We're kind of at a point where I'm okay with, as long as you guys are going to study, and you guys have been doing pretty good. So let's, I'll send out an email for everybody. We're not going to have class, but use the time to study, whether you guys come down here, study in a group, whether you guys group up at Leedy and study, use the time to study. I'm telling you, this test is going to be a little bit harder than the last test. Okay, so make sure you read your chapters 9 through 13, do your unit reviews, and the into section reviews.
Yeah, well, this one seems easier than last.
It may, it may end up being